So welcome everyone. I'm so thrilled that you could join us here today. My name is Jessica Fromm, and I am the Manager of Global Health Impact at the Canadian Partnership for Women in Children's Health, or CanWaCH. And we're so excited to be hosting this conversation in particular. I'm so glad that you could join us. CanWaCH is, for those of you who don't know us very well, we are a network of over 100 organizations, both in Canada and global associate members, who are working collectively to address critical issues in global health and gender equality. And we do this through a variety of strategies. And one of the key ones is through an emphasis on capacity building. So this is making sure that our membership and our global partners have access to resources, information, experts, and opportunities to come together to address critical issues and think about how to apply those learnings to and we try to prioritize topics that where there's a bit of a gap or identified gap in our community's knowledge. And this topic today, neglected tropical diseases, and in particular, the impact on the health of women and girls, has been something that's come up quite a few times for our membership as being an area where there's a lot of limited information or knowledge and confusion about how to apply that to your work. So we are beyond thrilled to have a group of great panelists here today to take us through that. Before we get too far down, I want to just take care of some housekeeping items for those of you who haven't perhaps used Zoom before. So down at the bottom left-hand corner of your screen, you should see a small microphone. If you click that, and most of you are muted, if you click that and mute yourself when you're not talking, that's ideal, as that will minimize any sort of feedback. If you want to ask a question, feel free to just go ahead and unmute yourself and ask. We're all friends here. But if at any point you want to just note a question or ask it for later, or if you're having any technical difficulties, you can message in the chat. So down at the center of your screen and slightly to the right, you should see a small chat bubble that has 3 dots in it. If you click that, you should see a chat feature open up, and you can message me directly. I'm just going to put a little note in here. So that should pop up for you. You can message me directly or to everyone in the whole group to ask your question. And I will be moderating that and making sure that those questions get asked. Finally, I'll just say that we are recording this webinar to make it available after the fact. And we'll also have the PowerPoint presentations that our presenters will be sharing available to you. So don't worry about that. And then, of course, CanWaCH is a Canadian organization, proudly bilingual. So we encourage you, as always, to ask any questions that you have in the official language of your choice. We will be having today's conversation take place in English, but we can easily do a translation for you if required. Comme toujours, on vous encourage ici de poser tes questions dans la langue officielle de votre choix. Et si c'est nécessaire, on peut faire la traduction du question ou de réponse. So with that, I would like to turn it over to Dr. Alison Krentel, who is going to be leading us through this discussion. Dr. Krentel is an assistant professor in the School of Epidemiology, Public Health, and Preventative Medicine at the University of Ottawa. She's also a scientist at the Briere Research Institute and an honorary research fellow at the London School of Hygiene and Tropical Medicine. Before coming to Ottawa, she worked as a consultant for UNICEF, the German government, and various NGOs. And Alison is also a founding member of the Canadian Steering Group for Neglected Tropical Diseases. So welcome, Alison, and with that, I'll turn it over to you.
Thank you very much. Great, thank you for that introduction, and very, very happy to you all. Very happy to have a terrific panel of speakers who have agreed to join us from various time zones across the world. So we're really grateful to have them with us today. I just want to, my role right now is just to give you about a 2 to 3 minute overview of some of the key neglected tropical diseases and just introduce you a little bit to the session and what we're going to cover today. And I do not want to take up too much time so that we can hand over to our various speakers. So Jessica, if you could go ahead and load my slides, that would be great. Super. Okay. So our focus today is really to think about the NTDs, what we call NTDs, which is a shortened version for neglected tropical diseases, and understanding the impact that they can have, particularly on women and girls, as this is an area of importance and focus globally, but also particularly here in Canada. And just talking a bit about the impact and looking at some opportunities for the CanWaCH community on how you might become more implicated in the global pursuit to eliminate these diseases. So if you could go to the next slide, please. So if you go to the WHO website, and I've given you the link there at the bottom, there's a list of 20 diseases that are considered neglected tropical diseases. These are diseases that disable, disfigure, and sometimes kill. Many of these you will have heard of before, and some of them may be completely new to you, and probably even if I asked you to say them out loud, you might struggle with the pronunciation. And you're not alone. But this is the list of diseases here that are considered as neglected tropical diseases by the WHO. I've highlighted 10 of them, and the reason I have highlighted these 10 diseases is that they are the focus of the London Declaration on NTDs. And this was signed in 2012 in London, and it was really inspired by the WHO 2020 Roadmap on NTDs. It's a public-private agreement that has committed donors, governments, pharmaceutical companies, WHO, to the control and elimination of at least 10 of these diseases that are highlighted here by 2020. So there's a big global movement underway right now as we approach 2020. And just an important note, many of the treatments that we use for these diseases are donated free by pharmaceutical companies or are offered at a very, very low cost. Next slide, please. So the countries that are affected by NTDs by income group, you'll note that predominantly they are low income and lower middle income countries. The important takeaway from this slide also is that 100% of low income countries are affected by at least 5 NTDs. So there's a real significant burden in these countries that continue to contribute to poverty. One more slide, please. Thank you. Global distribution. Approximately 1 billion people are affected by more than one of the NTDs, one or more. So this is, the burden globally is significant. And in many of the countries where you are working already, there will be the presence of 1 or more NTDs. And this map shows, particularly if you note in sub-Saharan Africa, the burden of 5 or more diseases is quite high. Brazil as well. And then if you look in the Sierra region in Southeast Asia, around 3 to 4 diseases. And the last slide, please. Or sorry, the next slide, sorry. So some key achievements, and I know Dirk's going to talk a bit about this, so I will only highlight a couple of these. 1 billion people were treated for at least 1 neglected tropical disease in 2015 alone. So this is an enormous international achievement that everyone was very proud of, and really involved millions of people who were working together to achieve this goal. Another important, some of the other key achievements to date, there are only 25 human cases of guinea worm disease, so we feel that eradication is close at hand. There's been significant gains with regards to sleeping sickness, and also trachoma and leishmaniasis also. And Margaret's speaking to us from Ghana today, which announced the elimination of trachoma this year. And the last slide. So what are our objectives for today? We'd like to, Dirk will give us an overview demonstrating the importance of NTDs with regards to the SDGs. We'll talk about the impact on women and girls, highlighting specifically female genital schistosomiasis, LF, and Buruli ulcer. We'll look at trachoma and the impact on childhood mortality, and then end with an example from a Canadian NDGO, beg your pardon. So we're really hoping to spark your interest and generate more Canadian interest and commitment in this area. So I will not speak anymore because we've got wonderful speakers lined up. And I think I'll hand over to Dr. Dirk Ingels, who retired in 2017 as director of the Department of Control of Neglected Tropical Diseases at WHO Geneva. And presently he's a consultant for Uniting to Combat NTDs. Prior to that role, Dr. Engels was previously the coordinator of Preventive Chemotherapy and Transmission Control Unit at WHO Geneva, and has written much on this subject. So I'm happy to turn over to Dirk. Thank you very much.
Thank you, Alison. Can you hear me? Can everybody hear me?
Yes, sorry, I just had to find my unmute button. Yes, so I can hear you very well.
All right. So what I would like to do is to highlight the link between neglected tropical diseases and the Sustainable Development Goals, in the sense that, on the one hand, the Sustainable Development Goal framework is really an opportunity to move the NTD area forward. But on the other hand, I also believe that NTDs provide an opportunity for the SDGs to implement the SDGs and to specifically make sure that the second part of the SDG mantra, leaving no one behind, is actually fulfilled. Next slide. I would like to start by reminding you the underlying determinants of NTD and the interventions that WHO proposes for the NTDs. Alison has alluded already to the link with poverty, and that is something we have heavily promoted because, in fact, the fact that for years no progress has been made with NTDs is actually linked to the fact that there are only poor people that are affected. That means people who cannot pay for treatment or prevention, and that means that the international community had no incentive to actually, as there were no commercial market, to develop new treatments or new appropriate tools for them. Now, they are all medical conditions that find their origin in the way that poor people live, without inadequate sanitation and in close contact with their domestic animals and livestock, including also infectious vectors. So if you look at those, then the solutions take their origin directly in that. There are medical solutions, of course, as it are medical conditions. Diagnosis and treatment is a solution. But here we have two groups of diseases. Some that you can treat in a preventive manner. That means that from young childhood onwards, you can treat children and populations regularly with medicines that are easy to administer, that are single dose and safe, so that they don't develop the chronic consequences of those diseases. For other diseases like sleeping sickness or visceral leishmaniasis, for instance, those diseases become apparent more quickly. And here it's an approach of early case detection and management that is the solution. Now, for these medical interventions, as Alison has already mentioned, we made tremendous progress thanks to the fact that we have negotiated with the pharmaceutical sector that some old and off-patent medicines have become available free of charge for endemic countries and free of charge to the end user. And that has allowed the tremendous progress in implementation of these medical interventions. Now, the medical interventions do not attack the root causes of these neglected tropical diseases, of course. And here we are at a stage where we really have to do more about provision of safe drinking water and sanitation, about vector control, and about veterinary public health, or promoting the One Health concept. Now, that goes far beyond the health sector, of course, and it is more complex to put in place. But here, and the next slide, please. And here, the development frameworks can be helpful. This slide gives you an idea of where we are in terms of progress with medical interventions. And we came close to the 1 billion people covered with NTD treatments in 2015. That has further been sustained. And in 2060, there were slightly over 1 billion people covered with well over 1.5 billion treatments, because some populations or groups deserve 2 treatments a year. And in 2017, that will be most likely well over 1 billion. Now, another consequence of this sustained delivery to so many people is that after a number of years, for certain diseases like trachoma or lymphatic filariasis, you can stop treatment. And you can just do surveillance in these communities. And in 2016, actually, we have been able to take 400 million people off the denominator of the number of people that needed to be reached with NTD interventions. And in the graph here, you can see for different categories of countries, how the number of people that need interventions move to the left, so decreases. So that also means that if we continue with sustained progress in this sense, that by 2030, 10 years from now, or a good 10 years from now, there won't be that many people left that need interventions for NTDs, and we will reach elimination or near elimination of most diseases, making it easier for health systems and health services to deal with the residual problems. Next slide, please. Now, since 2015, with the beginning of the SDGs, there are actually challenges of a new kind. For the medical interventions, I mean, the focus is now on integration in national health system and in universal health coverage. I mean, we've been building up these interventions, I wouldn't say in a vertical way, but in a globally directed way, I would say. And in the next 10 years, we must make sure that that becomes part and parcel of health systems and peripheral health activities. The second challenge is how can we build NTD interventions into activities of other sectors. And the number of sectors are quite large. There is education, there is water supply, there are municipalities and local governments, if only for sanitation or improvement of peri-urban settlements. There is agriculture, there is livestock management, and veterinary public health. There is water conservancy and fisheries, you name it. So that is a very complex issue of how we can push NTD interventions with those different sectors. Next slide. On the other hand, I also believe that NTDs offer an opportunity for other sectors and for the health system to reach their goals, whether it be universal health coverage or the sustainable development goals related to other sectors. And the secret is in these few words. Next, please. That is leaving no one behind. Next. I think the NTDs offer an opportunity to tailor the interventions and to tailor development to the need of the poorest communities, who actually need most development and where development will have the highest impact. For instance, NTDs can be an opportunity to bring appropriate healthcare to the poorest communities. And when I say appropriate healthcare, that means that the package is not necessarily the same that you're going to implement in the capital of an endemic countries, because these poorest communities have also different needs. By implementing an NTD interventions, there may also be collateral benefits for the poorest that we don't intend with the NTD interventions, but that are there. We can also, as I just said, tailor the package to the needs of the poorest. And then I believe for the other sectors, areas where NTDs occur can be considered as a proxy for the poorest areas. So that allows them to direct the development to where it is most needed and where the interventions will yield the most benefit. Next. And I would like to give 3 examples out of many, and the other speaker will give more details about this. First of all, the example of large-scale preventive treatment in communities who do not necessarily have a regular contact with the health system. Sometimes these preventive treatment interventions are the only opportunity for a contact with the health systems once or twice a year for these communities. And there is an opportunity to bring additional interventions and collateral benefits to these communities. For instance, the APOC example has taught us that home-based early malaria treatment can be implemented. Vitamin A delivery can be brought to the poorest communities. And then more recently, we have an example that preventive trachoma treatment can actually have a broader impact on mortality in very young children. I think Camilla Bucker will talk about that. An example of linking the package to our, adjusting the package to the needs of poor communities is female genital schistosomiasis is a very good example. I've just been back from the International AIDS Conference where we had 2 sessions on female genital schistosomiasis, and there the discussion was not necessarily so much on whether this has an impact on HIV transmission or not, but rather on if you don't include this in the package for the poorest communities, you're going to neglect an important potential prevention of HIV for these poor women and girls. And then the last example I want to use, and I think maybe Manesh is going to talk about that, is the using the NTDs as a tracer for equitable access to WASH. It provides an opportunity to make sure that, as a matter of priority, the public investments in WASH are directed to the poorest communities. So that is what I wanted to say. Thank you.
Thank you very much, Dirk. That's a great, a wonderful interview of the the intersection and the importance of NTDs on SDGs. What I would encourage everyone to do is just so that we give enough time for each of our speakers, if you could make a note of questions that you have for Dr. Engels and also for our speakers that are coming at the end. Hopefully we'll have some time to look at those. So without further ado, I think what I'll do is introduce Professor Margaret Jayapong, who is coming today to speak to us from Ghana. She is the Director for the Center of Health Policy and Implementation Research at the Institute for Health Research at the University of Health and Allied Sciences in Ho, Ghana. Margaret is a medical anthropologist by training and has served as a consultant for WHO, and also has received some international awards for her contribution to public health and NTDs as well as malaria. So Margaret, over to you, and thank you, Dirk.
Thank you very much, Alison. And it's a pleasure to be on this webinar to share some of the experiences that we have had with regards to NTDs, focusing particularly on female genital schistosomiasis. So I'll be looking at the interaction of neglected tropical diseases with the health of women and girls. I'll be looking at three conditions: lymphatic filariasis, Buruli ulcer, which are debilitating and are obvious on the physical body of somebody who has it. And then we'll go on to schisto and then female genital schisto. You don't see physically on the body, but the woman is suffering silently, and then I'll go through that. Next slide, please. So lymphatic filariasis is one of the conditions that Alison mentioned when she went through the long list of WHO NTDs. And we have over 120 million people infected and about 1.3 billion more in more than 80 countries who are at risk of the infection. The drugs that are used against this condition are donated or very inexpensive, like DEC, and the drugs are donated for mass drug administration in complete districts where people are at risk. It is transmitted by the mosquito, and you need several bites to be infected. Now you have the acute phase of the disease, and then it goes on to the chronic phase of the disease, and then it affects the extremities of anybody who gets infected. So from the pictures I've shown, you see a woman who has elephantiasis of the leg. It affects the breast, and then it affects the genitals too for women. So these are obvious things that you see on the women, and I'll talk about the consequences of some of these things later on. Next slide, please. So then we also have Buruli ulcer, a condition which is also debilitating. It starts with a little nodule, and then people get uncomfortable with the nodule. They may try to open it up or try to deal with it in their own ways, especially using local treatment and herbs. It becomes like a sore, a very deep sore, and it eats up the affected part of the body. In the second picture, you can see, I mean, you really need to go to a health facility to get it properly cleaned and treated, and people are given antibiotics. It takes a long time to heal. Sometimes it gets reinfected, and sometimes people need to go for surgery, but some of the conditions don't heal properly, and then you have people getting various forms of disability, either of their upper limbs or their lower limbs. Now, the severe skin disease remains shrouded in mystery, because sometimes trying to identify how people get it, where they get it, is a problem. Let's go on to the next one. Next slide, please. Schistosomiasis, endemic in about 53 countries in the Middle East and most of the African continent. And in sub-Saharan Africa alone, it's believed there are about 112 million infections with Schistosoma hematobium. The treatment is a single dose of praziquantel, 40 milligrams per kilogram body weight. It is very safe and effective. Now, people get it by going into water bodies. So people are along the rivers. They don't have a source of potable water. So the river becomes a source of everything for washing, for drinking. Children swim in those rivers. Women go to get water for household chores, and that is how they get infected. And in the middle picture, you see some bloody looking liquid. It is urine. So people pass blood in their urine when they get infected by the snails that are in these water bodies. Next slide, please. So what is the impact on these diseases on women and girls? The first one I'll look at is the exposure due to the roles that they play as women and girls. In Ghana, for instance, in the southern part of the country, you find a lot of women exposed to mosquitoes based on the kinds of work they do. Their main activity is fishing, catching shrimps in mangrove swamps, and they get several bites from being there. They have to go to the farms early in the morning. They are there sometimes till late in the evening, and they get exposed. And then we saw the pictures of schisto, where they, as part of their roles, they just need to go fetch water in those river bodies to be able to cook at home, to be able to clean, to be able to wash, and children are bathed in those river bodies. As a result of this and some of the debilitating conditions that they face and some of the disabilities they have, they are not able to do some of their household chores, particularly with lymphatic filariasis. When somebody is going through an acute phase of their condition, they have fevers, they have chills, they have pain, their limbs are swollen, it's painful to touch, and so they are not able to perform the roles that they have to perform as young girls and women. Now, when it affects the breasts, we are talking about lymphatic filariasis, then breastfeeding becomes a problem. So they have children, they cannot breastfeed, and it becomes a source of worry. Now, for the conditions that show physically on the body, then stigma becomes a problem because you are not like any other normal person, and so you are stigmatized. So some young girls who have huge legs due to elephantiasis cannot go to school because they are afraid of being teased. And then young girls who have these conditions on parts of their bodies find it difficult getting espoused because nobody wants to marry somebody who has a condition that is affecting them so badly. Then when you have the genitals being affected, then there's pain during sex, so you are married, and then it creates all kinds of problems. And then even in some of the health facilities, there's misdiagnosis. So a woman has genital schisto, arrives at the health facility, it is seen as a gynecological problem, and the basic issue may not be addressed. Next slide, please. Then you have women suffering all kinds of other conditions, anemia, gynecological conditions, disfigurement, blindness, and then they have the increased risk of other diseases, which Dirk highlighted with regards to female genital schisto and HIV. And then the loss of work and time and compensation as a result of not being able to go to work when they are suffering these conditions. Next slide. So now I want to highlight female genital schisto, and we put together a publication, my colleagues on the Countdown Project and we put together a publication in Open Democracy titled The Sexual and Reproductive Health Issue You've Never Heard Before, Female Genital Schisto. Next slide, please. So it's a condition that is caused, of course, by the schistosoma parasite, and it's an invasion of the upper and lower genital tract. It was first reported several years ago, but it is still a neglected problem amongst the neglected tropical diseases. So remember when I spoke earlier on, I talked about the conditions that are obvious for people to see, and this particular one is not obvious. It's hidden in the genital tract of the woman, and it affects almost every part of the genital tract. Next slide, please. So it affects the ovaries, the fallopian tubes, the uterus, the cervix, the vagina, and it leads to all kinds of consequences of having these parts of the body affected. Ectopic tubal pregnancies, anemia because of chronic blood loss, miscarriages, preterm delivery, risk to STIs, and then sometimes destruction of the hymen. And you can imagine all the sociocultural consequences of a woman going through all of these problems. Next slide. So as part of the Countdown project, we were interested in finding out some of the issues surrounding female genital schisto. We informally talked to a few healthcare providers, and they were like, they were taught in medical school, but they don't remember seeing any of these cases in the health facilities. So we did a purely qualitative study to find out what people know about it and what they do about it. And in this slide, what I've done basically is to just highlight some of the quotes that we picked up from the field, having spoken to healthcare providers and women in some of the communities. So we realized from the quotes that people really don't know what it is about, and they are mixing it up with different kinds of diseases. So the first one, when you eat sugarcane from the river bank, you will swallow the snail and it will hatch in your stomach and cause schisto. Then in a focus group discussion with teachers, they are saying married women and girls sleep with married men and God punishes them with schisto. And then a midwife says, I've worked here for 12 years and have never seen a girl report with bloody urine. It's always the boys. And I don't think the girls get the disease from the lake like the boys. And the medical doctor also saying, we were taught about it in school, but I don't think I've seen a case like it before. So there's not much information out there on female genital schisto. People are mixing it up with STIs, mixing it up with different kind of things. And there's the need to really go into a lot of detail and to do a lot of studies to unearth what the key issues are. Next slide, please. So what are the implications for disease control when we talk about female genital schisto? Basically, there's very little knowledge and understanding of the condition in the communities. And some key groups, teachers, schoolgirls, and boys, were not able to describe the symptoms and the reproductive health effects. Sometimes they were mixing up the symptoms, like I said earlier on, of FGS and STIs. And this led to health workers stigmatizing young girls and women who came to the health facilities seeking care. And women and girls are less likely to be identified at being at risk of schisto because it is seen as a disease which mostly affects boys. And the intervention strategies that need to be put in place should consider the broader context in which some of these things work. Next slide, please. So what are some of the issues that we need to consider in tackling some of these NTDs, in particular female genital schisto? There's lack of gender disaggregated data on the burden of these conditions, and we need to focus attention of breaking these data that is available out. And there's the need for better data on the complications of NTD infections, particularly something like FGS, which, like I said, is not obvious, it's hidden. It will be treated as maybe a gynecological problem rather than seeing it as an NTD. So maybe it's better for us to put FGS on the maternal health agenda so that it gets the needed attention. Otherwise, it gets neglected amongst the neglected tropical diseases. And it's important also for us to look at the relationship between NTDs and other diseases, particularly when it comes to women and children. I think I'll end it here. Thank you very much.
Thank you, Margaret. It's a wonderfully rich presentation that I think we could probably spend a lot more time on, and I won't talk very much now because I want to leave time for Camilla and MNCH to reach out to us. But I'm sure this will spark some questions, so please do mark those in the chat box. We're pleased to have with us Dr. Camilla Drucker, who is a clinician and public health consultant who's currently working at the Bill and Melinda Gates Foundation. Previously, she was with the Department of International Development in the UK and managed many of their NTD programs. So we're grateful that she's here with us, and she's going to talk about trachoma and the impact on child mortality. So thanks very much. Thank you, Margaret. And over to you, Camilla.
Thank you very much, Alison. And I'm going to talk, introduce trachoma a very little bit, and then talk about the Mordor study and the results that were published this May. So just very quickly, and some of the implications. Next slide. So for those who don't know, trachoma is the world's leading cause of preventable blindness, infective cause of preventable blindness. It's caused by contagious bacterial infection, actually chlamydia, and it's children who get infected, but they go on to have reinfections and into adulthood, and eventually the eyelid turns inward, causing the eyelashes to actually scar the cornea. Next slide, please. And once that happens, that's called trichiasis, and this is a picture of it. It's incredibly painful, as you can imagine. As you're blinking, the eyelashes are rubbing against the cornea. Next slide, please. The causes are the flies are one of the causes. They spread the bacterial infection, but it's also linked with poverty, like all the NTDs, with poor sanitation, and with lack of water, clean water. Next slide, please. So the WHO published a safe strategy as an approach to treatment and prevention of trachoma. That's surgery for those who have trichiasis, where they can turn the eyelashes round and stop the scarring, facial cleanliness and environmental improvement, but also 1 dose of azithromycin per year to children under the age of 5, and that prevents that early infection and therefore the reinfections. Linking this to the topic that we're talking about today, women are actually at about 4 times the risk of trachoma, and that's thought to be because they're in so much contact with children who are infected, and to do with the caring role. Next slide, please. So to move on to the TANA study. So the TANA study was carried out ended about 10 years ago, and it was in parts of Amhara, the northern Amhara, and it was looking at the fact that when you're distributing azithromycin, it actually seemed to reduce child mortality. There were estimates that it was about a reduction of 50% in all-cause mortality, but it wasn't fully powered. And so another study was then commissioned, and that was called Mordor, and that was funded by the Bill and Melinda Gates Foundation. Next slide, please. So obviously, there's a concern about child mortality, the under 5 child mortality, because although there is a decrease in it, there's still it's still high, and it's particularly in the infants, the 0 to 11 months. Next slide, please. So the implication is we are leaving children behind. So Mordor was conducted. It was looking at biannual azithromycin, so 1 dose of azithromycin to be given between 1 month and 60 months, so 1 month and 5 years, twice a year for 2 years, and it was very large, so that we could look definitively at whether there was a reduction. Alongside this, there were many interventions, as many interventions as could possibly be thought to reduce mortality, to try and reduce the bias, so that it could be seen what if there was a reduction, what was causing that. So it's 4 rounds of MDO conducted, and it was in Niger, Malawi and Tanzania. And just to sort of give an overview of the results, where the child mortality was highest, which was in Niger, the biggest reduction was seen. In Malawi, slightly less, and in Tanzania, even less, and not significant. And the strongest effect was in the 1 to 5 month age group. So that 25% reduction if you look at all 3 sites. When they looked using verbal autopsy at the reductions in death, it seemed that the reductions were not due to a specific syndrome. So you would have thought it's a broad spectrum antibiotic, azithromycin, that this might have been due to its antibacterial effect, but that doesn't seem to be the case. It seems to be that there was a reduction in all-cause mortality, and so that mechanism of action still not known, but it's thought to have something to do with a boost to the immune system through the biomes in the gut. Next slide, please. So this is just to sort of show the results again. So the results in Niger shown to be significant, as I say, in Malawi and Tanzania, where the under 5 mortality was lower, the impact does seem to have been less. Although the impact does seem to be more with that still, with that under 6 month group. Next slide, please. So that's the second one when you see the younger children. Next slide, please. So, oh, this should say more than this. But yes, what are the public health implications? The WHO are considering all the evidence at the moment, and we hope to have some sort of recommendation within the next year. But this is very, obviously very exciting, but there are lots of questions that are being raised around it in terms of the public health implications of an intervention which is with an antibiotic. So resistance, safety long term, and are just some of those, and they're being obviously considered and thought about in how we go forward with this. But the sort of question that I put out there is, you know, what do we do with this? Obviously this is exciting, but where do we go next? So it has huge public health implications, but yes, it's a ... So that's a very quick overview of both trachoma and the Mordor study. Thank you very much.
Thank you, Camilla. That was great. And my apologies, because she sent an updated slide deck and I did not send it on to Jessica. So please forgive me. The last slide, that was my fault. But I think that'll be of interest, certainly to many of the Canadian groups that are working on childhood mortality. And so we appreciate this overview, and certainly just a brief introduction into a very rich and important study that's been done. So thank you very much. We've got one last speaker, MNCH Philip, who is the Director of International Programs at Affect Hope, previously called the Leprosy Mission, based here in Canada, in Ontario. MNCH has worked for national and international organizations globally, and is going to present to us today just an example of what's possible here in Canada in terms of integrating NTDs into MNCH programming and WASH programming. So we'll look forward to hearing from him. And MNCH, unfortunately, you're the last speaker, so we thank you for adapting to our time, which is running a bit over. And there's a bit of things coming up in the chat box, but hopefully we'll have a couple of minutes for a brief discussion at the end. So go ahead, MNCH, over to you. Thank you, Camilla.
Thanks so much, Alison, and hello to everyone on this webinar. I will just talk very quickly because I have less time, and try and cover everything on my my slides. Next slide, please. Okay, so why NTDs matter to MNCH programming? You've heard a lot about this already. It has huge impact on some entities on MNCH. One example is soil-transmitted helminths, and these are also called intestinal worms. I've given some down there in those pictures. They cause severe anemia and contribute to complications during pregnancy, and of course, malnutrition in children, leading to a lack of cognitive development. How can they be treated? Albendazole twice a year, mebendazole, which is drugs donated by Johnson & Johnson and GSK. In children, deworming has been shown to improve physical growth and nutritional status improvement, which improves learning and school attendance and enhances a long-term economic earning potential. Since the launch of the London Declaration, which Alison mentioned earlier, there has been significant progress in reaching more children with deworming medications. More than 1 billion people are affected by SDH, most of whom are children. And the annual burden contributes to over 5 million Dalis, and most of these children are located in the low and middle income countries. Next slide, please. So an example of NTD and MNCH programming. At Effect Hope, we have Global Affairs Canada project called Every Child Thrives, which some of you may be familiar with. It is implemented in the countries of Kenya and Cote d'Ivoire. The problem is that malnutrition and disease in children under 5. The strategy we apply is combined vitamin A supplementation and deworming for eligible children under 5. The impacts are huge, as I said: improved nutrition, better cognitive aptitude, more likely to go to school. These children are more healthy and live a more productive life, and eventually contribute more to the local and national economy. Next slide, please. This is just a logical framework. I will not delve into it. It could be quite common to most of your programs for the NGO partners here in Canada. Next slide, please. What does the Every Child Thrives program do? Just quickly, I'll run through these slides, which will give you a good idea of what the project really means. Jessica, if you could, yeah, thanks. So if there is a child, the child is hit by a disease, we prevent it with preventive chemotherapy, so a deworming medication. The child gets protected. Next. Children get protection against disease, but these diseases also cause a loss of essential vitamins and minerals. But children don't get the vitamins and minerals they need to promote optimal growth and development. Next slide, please. Ultimately, this means little or no significant increase in child health. Next intervention, micronutrient supplements only. Child hit by malnutrition, we prevent it by micronutrient supplementation. However, the disease still hits the child. Children get the vitamins and minerals they need, but their optimal growth and development is hampered, and no protection against disease that cause loss of these essential vitamins and minerals. And ultimately, little or no significant increase in child health. Then there can be a combined but out of sync intervention. These two interventions can be done, but they can be out of sync, which still causes disease and still causes malnutrition because of the gap between these two interventions. And this is often the case that we see in many countries. Both interventions give benefit to the child, and there are some positives, but the time between interventions still allows space for disease and malnutrition to set in. Next slide, please. This ultimately means that there is only temporary growth for children. Now, an in-sync combined intervention. You have both these interventions done simultaneously, which protect the child. And this is what is Every Child Thrives. We ensure that both interventions give benefit to the child, both interventions are in sync, and this is an opportunity for health and growth, which is fostered for all children under 5. At ECT, we are developing toolkits for standardized integrated microplanning, standardized training, standardized tool for developing contextually relevant communications materials, and standardized tools for data collection and supervision. And this is in a nutshell the program. Some of the key achievements are in the next slides, and I'll just run through these. In Côte d'Ivoire, we've been able to cover more than 90%. Next slide. In Kenya, we've been able to have a coverage of more than 80%. And so much so that the Kenyan government asked us to roll out to another 10 countries, 10 counties of the country. Some of the key messages that in the end I would like to share is that there are straightforward and highly cost-effective strategies that are available to control and eventually eradicate NTDs. And so there could be easy strategies that you could combine with your MNCH programming. The success and control of NTDs depends on partnerships, as most of you very well know. Partnership with multiple actors can be very challenging, and NTDs have a direct impact on the achievement of SDGs, as Dirk pointed out early in the discussion today. And without addressing these diseases, the broader aim of poverty alleviation is unlikely to be achieved. So that was very quick. I hope I've made my time. And for further collaboration, please get in touch with Alison or myself here in Canada.
Thank you, Manish. That was brilliant, and I liked the way that you've demonstrated these interventions. I think it's really great, and I think it will be useful for our Canadian partners who might have existing MNCH programs, just to understand some options available for them. We're close to the hour, but there's a couple of questions that have come up that would be great to just try and address quickly. Margaret, do you want to perhaps just, there was a question that came up earlier about research that's being done in the area of FGS. And so I wonder if you wanted to just quickly speak to that. And then we have a question that's come in about barriers. So Margaret, perhaps I'll just over to you for a quick response to the FGS question that came in earlier.
I responded to that question a few minutes ago. But basically to say that the issues of FGS are quite new, and people are only just hearing about it. There are a few research groups which are doing clinical and parasitological studies. I know of 1 or 2 groups in the Netherlands and some in South Africa. In Ghana, there's just been one group with the university that has done some parasitological work along the Volta Basin. And with our research group, we have now started looking at the factors contributing to the problem, people's knowledge and perceptions about the disease. So it's fairly new, and there are opportunities for a lot more research in these areas.
Thank you very much. Yes, Dirk, I was going to say, yes, please. I was going to suggest, coming from Amsterdam, please.
I have recently started working with UNAIDS, actually, to make a case to include that in AIDS prevention and screening programs. And with reasonable early success, I would say. And as I briefly mentioned, I've just come back from the International AIDS Conference, where we had 2 sessions on it, one in the formal part for all the registered participants, but then also one in the Global Village, you know, the more activist part of the UNAIDS conference, and both stirred up a lot of interest. And it was really about programmatic integration. In fact, we've teamed up with the cervical cancer prevention people in WHO, because there are similarities. I mean, it's also something that you have to prevent early during the schooling period by vaccination, HPV vaccination. And it is very often also these lesions of early cervical lesions are not taken care of in poor African context. So it was all about programmatic integration. And for the people in the conference, that made perfect sense. So I hope that like that, we can push it further with the different components, systematic treatment of all school-age children where schistosomiasis is, but once they get out of school, also accompany them through other mother and child health programs and build that in mother and child health programs. Again, I say this is maybe not something that you're going to implement all over the world, because you don't have to do that where there is no schistosomiasis, but in Africa that perfectly makes sense, and that we build capacity to do that.
Thank you very much, Dirk. That was fantastic. I see some other questions coming in, and I'm so sorry that we're not going to have time to get to them, because I know that there's lots of interest. So what I'd like to suggest is a couple of things. I've put my email address in the chat. It's jferne, JFERNE at canwatch.ca. If you have additional follow-up questions or you want to know more about this topic, we would love to consider hosting a part 2 that really does a deeper dive into some of these topics, or getting you some of those resources. So please continue to post your questions in the chat or email them to me, and I'd be happy to broker kind of the next part of this conversation. As well, Manish, you had mentioned people who want a bit more information, and of course you mentioned the toolkit, could contact the steering committee. What is the best contact information? Is it your and Allison's direct contact information? Is there the best way to get a hold of the steering group? What would you recommend?
Yes, you can get in touch with us directly.
Wonderful. So perhaps what I will do as well is, once we put all these materials together, I can make that available for those on the call to be able to reach out to you directly if they're looking for more tools and more resources. Fantastic. Allison, do you have any final words you wanted to share?
I just wanted to thank our speakers. I wanted to thank our participants, and there's some very rich questions that have come up that would be really good for us to talk about. So maybe there is an opportunity to do a version 2 of some of this. And just want to thank Dirk and Margaret and Camilla and Manish for taking the time to contribute today, and for CanWaCH for co-hosting this with us. So thank you to everyone, and Jessica for your excellent direction. So thanks everyone.
Not at all. Thank you, everybody. Thank you to our speakers. Thank you, Allison. Thank you to the steering committee, and Allison has just shared that contact information. can.ntds@gmail.com. I do have all of your contact information. If you registered for this webinar, I will have your the email address that you provided to send to you, but also feel free to express your interest. Again, send me an email, and I'll make sure that you have access to all of this information. And I look forward to seeing you all for what I'm sure will be part 2 of this really important discussion. Thank you, everyone, and have a great rest of your day.